Mr. David Shun, 52-year-old male history. Stage for colon cancer, liver/lung mets. Day 5 post-cycle 1 FOLFIRI, 5 Fu plus irinotecan. No prior bleeding disorders. Presentation, brought to ED by wife. He's confused, has purple spots, and can't move his right arm. Vitals, T38.8 degrees Celsius, 101.8 degrees Fahrenheit. BP 168/94, HR 124, RR 28, SpO2 95% RA physical. Neuro, disoriented, right arm weakness, slurred speech. Skin, petechiae on trunk/palate, ecchymosis at IV site. Cardiac, tachycardic, no murmurs. Abdominal, mild epigastric tenderness. Stat labs. Platelets, 15,000/L, HB, 7.8 G/DL, LDH, 1,450 U/L, haptoglobin, less than 15 milligrams per deciliter, creatinine, 2.1 milligrams per deciliter, peripheral smear, schistocytes, 8%, PT/INR, normal, ADAMS 13 activity, pending. Diagnosis, suspected TTP. Which finding is the most urgent and requires immediate intervention? A. Epigastric tenderness. B. Slurred speech plus right arm weakness. C. Petechiae on the palate. D. Temperature 38.8 degrees Celsius, 101.8 degrees Fahrenheit. Answer B. Slurred speech plus right arm weakness. This is correct. Immediate action required. Signs of CNS microthrombi and TTP. In thrombotic thrombocytopenic purpura, TTP, widespread microthrombi form in small vessels. Neurologic deficits, slurred speech, weakness, confusion, indicate active CNS microthrombosis, placing the patient at imminent risk for stroke, seizure, or permanent neurological injury. TTP is a medical emergency, and delay in initiating plasma exchange, the definitive treatment, significantly increases mortality. This Q cluster is the highest priority because it reflects ongoing end organ damage with a narrow window for intervention. For Mr. David Shun with suspected thrombotic thrombocytopenic purpura, TTP, presents with confusion, slurred speech, right arm weakness, petechiae, and thrombocytopenia. The diagnosis is not yet confirmed, and ADAMS 13 results are pending. What is the nurse's immediate action while awaiting confirmatory testing? A. Administer aspirin. B. Place the patient on seizure precautions. C. Infuse platelets. Stat. D. Obtain a chest X-ray. Answer B. Place the patient on seizure precautions. This is correct. Addresses the immediate risk of neurological deterioration. The patient already exhibits CNS involvement, confusion, slurred speech, right arm weakness. In TTP, cerebral microthrombi can lead to seizures, stroke, or altered mental status. Placing the patient on seizure precautions, padded side rails, airway equipment at bedside, suction available, maintaining a safe environment, is a critical safety intervention that can be implemented before a definitive diagnosis is made. Nursing intervention action. Pad side rails. Keep the bed in a low position. Ensure suction and oxygen are at the bedside, and remove any potential hazards. Maintain close neurological monitoring. Notify the provider of the patient's seizure risk. Do not administer aspirin or platelets unless specifically ordered for life-threatening hemorrhage. Prepare for emergent plasma exchange once TTP is confirmed. For Mr. David Shun with suspected thrombotic thrombocytopenic purpura, TTP, presents with confusion, right arm weakness, slurred speech, petechiae, and thrombocytopenia. Which laboratory finding confirms the diagnosis of TTP? A. Low haptoglobin. B. Elevated lactate dehydrogenase, LDH. C. ADAMS 13 activity less than 10%. D. Presence of schistocytes on peripheral smear. Answer C. ADAMS 13 activity less than 10%. This is correct. Confirmatory for immune-mediated TTP. ADAMS 13 is a protease that cleaves von Willebrand factor. Severe deficiency, activity less than 10%, is diagnostic for congenital or immune-mediated, acquired, TTP. In the absence of another identifiable cause, This level confirms TTP and distinguishes it from other thrombotic microangiopathies, e.g., hemolytic uremic syndrome, drug-induced TMA. ADAMTS 13 activity is the definitive laboratory test for TTP. Mr. David Shun is diagnosed with suspected thrombotic thrombocytopenic purpura (TTP). The provider orders plasma exchange (PX). When should this therapy be initiated? A. After ADAMTS 13 results return. B. Immediately. C. After CT head is completed. D. After blood cultures are drawn. Answer B. Immediately. This is correct. Plasma exchange is the definitive, time-sensitive treatment for TTP. TTP has a mortality rate greater than 90% without treatment. Plasma exchange removes inhibitory autoantibodies and replenishes ADAMTS 13. Delay of even hours increases the risk of irreversible end organ damage, stroke, renal failure, cardiac injury. Studies show mortality increases by approximately 1.5% for every hour delay. Immediate initiation, often within 4 to 8 hours of presentation, is the standard of care. For Mr. David Shun, plasma exchange, PX, is being prepared. Which medication order is critical to implement before initiating PX? A. Type and cross-match. B. Methylprednisolone 1G IV-C. IV heparin infusion. D. Platelet transfusion. Answer B. Methylprednisolone 1G. For this is correct. High-dose corticosteroids are first-line pharmacologic therapy in TTP. High-dose corticosteroids, e.g., methylprednisolone 1G4 daily, are administered immediately upon suspicion or diagnosis of immune-mediated TTP. Steroids suppress the production of ADAMTS 13 autoantibodies, reducing the ongoing formation of microthrombi. This intervention should be initiated before or concurrently with plasma exchange. In the NGN framework, this represents a critical, time-sensitive pharmacologic intervention that addresses the underlying pathophysiology. Mr. David Shun is undergoing preparation for plasma exchange, PX, due to thrombotic thrombocytopenic purpura, TTP. During setup, the patient suddenly begins seizing. What is the nurse's priority action? A. Administer lorazepam. B. Protect the airway and turn the patient to the left lateral position. C. Hold the plasma exchange procedure. D. Check a bedside glucose. Answer B. Protect the airway and turn the patient to the left lateral position. This is correct. Airway protection is the highest priority during a seizure. During a seizure, the patient is at risk for aspiration, airway obstruction, and injury. Turning the patient to the left lateral recovery position helps maintain a patent airway, allows secretions to drain, and prevents aspiration. This action is taken immediately before administering medications and is consistent with basic life support and seizure management principles. In the NGN framework, this represents the highest acuity intervention, preserving airway and safety. Nursing intervention action. Immediately move to the patient's side. Lower the bed. Turn the patient to the left lateral position and protect the head. Do not place anything in the mouth. Activate the rapid response team if not already present. After the seizure subsides, assess airway patency. Administer lorazepam if indicated and check glucose. Resume preparations for plasma exchange as soon as the patient is stable. Mr. David Shun is receiving plasma exchange, PX, for thrombotic thrombocytopenic purpura, TTP. During the procedure, the nurse assesses the patient, which finding indicates citrate toxicity and requires immediate intervention. A. Hypertension. B. Perioral tingling and carpopedal spasm. C. Bradycardia. D. Urticaria. Answer B. Perioral tingling and carpopedal spasm. This is correct. Classic signs of hypocalcemia from citrate chelation. During plasma exchange, citrate is used as an anticoagulant. Citrate binds ionized calcium, causing acute hypocalcemia. Early signs include paresthesias, perioral tingling, numbness in fingers/toes, followed by muscle cramps, carpopedal spasm, Trousseau's sign, and if untreated, tetany, laryngospasm, or prolonged QT with arrhythmias. Recognizing these cues allows the nurse to intervene with IV calcium gluconate before complications escalate. Mr. David Shin has completed his first plasma exchange (PX) session for thrombotic thrombocytopenic purpura (TTP). Post-procedure, his platelet count remains 18,000/L. What is the nurse's next action? A. Transfuse platelets. B. Repeat plasma exchange daily. C. Start warfarin. D. Administer iron. Answer B. Repeat plasma exchange daily. This is correct. Daily PX continues until remission is achieved. In TTP, plasma exchange is typically performed daily until platelet count normalizes, typically 150,000/L, and lactate dehydrogenase, LDH, returns to normal, reflecting resolution of microangiopathic hemolysis. This process usually takes 5 to 7 days, though some patients require longer. A single PX session is rarely sufficient. Daily therapy is the standard of care. The nurse should anticipate and prepare for daily PX until remission criteria are met. Nursing intervention action. Prepare the patient for daily plasma exchange sessions. Continue corticosteroids as ordered. Maintain seizure precautions and frequent neurological assessments. Avoid platelet transfusion unless active, life-threatening bleeding occurs. Monitor platelet count and LDH daily to track response. Educate the patient and family about the expected course of daily PX until remission. Mr. David Shin has completed several plasma exchange (PX) sessions for thrombotic thrombocytopenic purpura (TTP), which finding indicates that treatment is successful and the patient is responding to therapy. A. Lactate dehydrogenase (LDH) normalizes. B. Platelet count 150,000/LC. Haptoglobin increases. D. All of the above. Answer D. All of the above. This is correct. Remission in TTP requires normalization of all three markers. Treatment success in TTP is defined by the combination of platelet count 150,000/L, cessation of platelet aggregation, LDH normalization, no ongoing hemolysis, rising haptoglobin, resolution of hemoglobin consumption. These three laboratory findings together confirm that plasma exchange and immunosuppression have effectively halted the disease process. In the NGN framework, recognizing this composite outcome allows the nurse to accurately assess treatment response and anticipate transition to maintenance therapy or discontinuation of daily PX. Mr. David Shun is being treated for thrombotic thrombocytopenic purpura (TTP) with daily plasma exchange and high-dose corticosteroids. Which medication is contraindicated in the management of TTP unless the patient has life-threatening hemorrhage? A. Platelet transfusion. B. Calcium gluconate. C. Rituximab. D. Acetaminophen. Answer A. Platelet transfusion. This is correct. Contraindicated in TTP without life-threatening bleeding. In TTP, the underlying pathology is widespread platelet-rich microthrombi that cause end-organ ischemia, brain, kidneys, heart. Platelet transfusion provides additional substrate for these thrombi, potentially worsening neurological deficits, renal injury, or precipitating myocardial infarction or stroke. Platelets are reserved only for patients with active, life-threatening hemorrhage, e.g., intracranial bleed. Routine transfusion for thrombocytopenia alone is contraindicated. Mr. David Shun is being discharged after successful treatment for thrombotic thrombocytopenic purpura (TTP) with plasma exchange and corticosteroids. Which discharge instruction should the nurse emphasize as most critical for the patient to recognize a potential relapse? A. Report any mild bruising. B. Report a severe headache with vision changes. C. Report fatigue. D. Report nausea. Answer B. Report severe headache with vision changes. This is correct. CNS symptoms are the hallmark of TTP relapse and require immediate intervention. TTP relapse carries a risk of approximately 40%. Recurrent microthrombi often first manifest in the central nervous system. Severe headache, vision changes, blurred vision, diplopia, scotomas, confusion, or focal neurological deficits are red flags for relapse. Prompt recognition and rapid reinitiation of plasma exchange are critical to prevent stroke or permanent neurological injury. This teaching empowers the patient to seek emergency care before the relapse progresses. TTP Nursing Code Blue. Step. Action. Why? 1. Suspect. Petechiae plus thrombocytopenia plus neuro symptoms. TTP PIN-TAD incomplete but treatable. 2. Protect. Seizure precautions, avoid falls. Microthrombi stroke risk. 3. Reject. NO platelets / anticoagulants / NSAIDs. Worsens clotting. 4. Connect. Central line for PX plus steroid stat. ADAMS 13 replacement can't wait. 5. Expect. Relapse signs, neuro / renal decline. 40% recurrence rate. TTP pathophysiology mnemonic. TTP crash. Thrombocytopenia. Thrombotic microangiopathy. PIN-TAD, fever, microangiopathic hemolytic anemia, MAHA. Neurologic symptoms, renal impairment, thrombocytopenia. Chemotherapy triggers, gemcitabine, mitomycin C, cisplatin. Renal dysfunction. ADAMS 13 less than 10%. Schistocytes on smear. High-dose steroids plus PX.